Yes, in Athens.
Yes, in
We can in Albany.
Oh, wonderful. Well, good morning, everybody. Nice to see you all again. We're going to be discussing the rest of lung cancer today. There is a quiz this morning. I think it should already be active for you to access. The password is BREATHE, B-R-E-A-T-H-E. We'll just take a few minutes to do that first. Alrighty, I think everyone is good to go, so we'll go ahead and get started. Just to remind you, the objectives for our lung cancer portion is to understand small cell and non-small cell lung cancer. And most of these points were covered in the pre-class lectures. And then we'll discuss some first-line treatment options for both small cell and non-small cell lung cancer, and then create treatment plans for these patients with some cases. And as just a reminder for the types of lung cancer, broadly speaking, we have two different types, non-small cell and small cell lung cancer, and these are very different cancers. They're managed differently, have different prognoses, and have a little bit different patient populations. So as I mentioned in the pre-class lectures, non-small cell lung cancer is by far the most common. About 80% of patients have non-small cell lung cancer. And in patients that are never or light smokers, they're far more likely to have non-small cell lung cancer. It's very rare for a never smoker to develop small cell. Small cell lung cancer is less common. It's also, of the two, the one with the worst prognosis. And as I mentioned, very rare in never or light smokers. So it does happen, but, and we know one patient that we had was here in Augusta that was a never smoker. So we'll talk a little bit about small cell lung cancer first. As far as first-line treatment options, there's a lot less to know for small cell lung cancer. Unfortunately, there hasn't been very many changes in the last 20 to 30 years, with the exception of the bolded regimen, which I'll talk a little bit about. As mentioned in the pre-class lectures, the backbone of treatment for small cell lung cancer is a platinum-based doublet. And typically, in a patient with that limited stage disease, so these are patients where it's confined to an area of the thorax where they can safely receive radiation. It's preferred, if they're getting radiation, to get cisplatin with etoposide. Though carboplatin is an option for a patient that may not be able to tolerate cisplatin, or in somebody who's not receiving radiation and, say, getting this as adjuvant after surgery. But by far and away, most patients with limited stage disease who get radiation will receive a cisplatin-based regimen, and we typically use etoposide with that. So in our extensive stage patients, so this is kind of equivalent to someone with stage 3 or 4 cancer. We have a few other options, but there are the ones that we use more commonly in practice. The one that I bolded is relatively new. In fact, I think the FDA just approved atezolizumab within the last couple of weeks officially for small cell lung cancer extensive stage. And this has been in the guidelines since maybe December of 2018. It's based on a new study. And if you recall from some of our discussion with melanoma, this is a PD-L1 inhibitor, so it is an immune checkpoint inhibitor, and it's in combination with carboplatin and etoposide for extensive stage only. And this is meant to be for patients who have not received treatment before. At least that's how it's studied. And so based on this study that looked at the combination of the 3 medications versus a standard doublet treatment, the addition of atezolizumab did extend overall survival a little bit. I think it was only about 2 months. But just to put that in some perspective, this is the first positive trial we've had in small cell lung cancer in about 20 years that something has actually improved overall survival. And these patients don't tend to have a very good prognosis, so 2 months can be very significant for these patients. So this has now been bumped up to the preferred regimen first line for extensive stage patients. And like I said, that's a relatively recent change. The other ones that are listed here were our other options. You can use cisplatin with etoposide, and then we do have options with irinotecan. We'll talk more about that medication on Friday when we talk about colorectal cancer, but based on the toxicity profile, we very rarely use those combinations with irinotecan. So if you go on an oncology rotation and get to spend time in a lung clinic where you're seeing small cell lung cancer patients, you're more than likely going to see the bolded regimen, since that's kind of been the practice-changing study to come out within the last year. All right, and then as a reminder, so I think some of these topics probably were covered in your first portion of your lecture, but since we use a lot of cisplatin, especially for limited stage patients, just wanted to review a little bit of the pharmacology with you. So this is a medication that's in the platinum class of medications of chemotherapy, and its mechanism of action is that it forms those DNA cross-links, helps to denature the DNA double helix, and results in DNA dysfunction, and that's how it kills the cancer cells. From what you may recall, cisplatin is our typical gold standard drug that we talk about with highly emetogenic chemotherapy. So this is the kind of poster child for patients who need a lot of CINV prophylaxis. It is a platinum agent, so it can cause peripheral neuropathy as well. And you may also recall that it is nephrotoxic. So when I mentioned those patients that may not be eligible for cisplatin, these tend to be patients maybe with baseline CKD. They may develop some sort of nephrotoxicity during treatment and need to be switched to an alternative. But that is something that we adequately pre and post hydrate for, and do a lot of counseling for patients to maintain good hydration when they're on a cisplatin containing regimen. Of course, it is myelosuppressive, so anemia, leukopenia, thrombocytopenia are all common with cisplatin-based regimens. And then patients can also develop ototoxicity. So the recommendation is to get a baseline audiogram, especially in younger patients. We use this drug in a lot of different cancers. It's one of our oldest chemotherapies. So sometimes this slips by on our older patients, say with lung cancer, where they may not receive one at baseline. But then it becomes really hard. You start asking them about hearing loss, and you actually don't know if it was something that predates the chemotherapy. So we try to get those as best we can. I'd be curious if some centers are a little bit better about getting them at baseline. I know we miss it sometimes, and it's something we're looking at for an NUV for students and residents. But best practice is to get a baseline, and then in the setting of any kind of ringing in the ears or any subjective hearing loss that the patient reports, kind of repeat that and see if a change needs to be made. But definitely for cisplatin, the things that we look at prior to a patient starting and making sure that they receive on the day of treatment and adequate prophylaxis for nausea and vomiting, and then of course lots of hydration while they're on this treatment. And then etoposide, so this is one of our topoisomerase II inhibitors. By itself, it doesn't tend to cause a whole lot of issues, but we often use this medication pretty much in combination with other chemotherapies. So it can cause myelosuppression. It can cause hypotension. This tends to be with larger doses and is related to the duration of the infusion. So for big doses, which would not be what we would use for small cell lung cancer, but maybe say in a patient who's getting a bone marrow transplant where they get a very large dose of etoposide, we tend to extend the infusion over several hours. And so then patients are much less likely to become hypotensive. With a regimen like this is pretty standard etoposide dosing, so it'll typically be infused over about an hour, and it's not something that we have to monitor as frequently in the clinic setting. But it's typically managed, like I said, by extending that infusion, and then if they're inpatient getting high doses, they'll have boluses available of normal saline so that the nurse can give it if they develop hypotension. And some patients do develop nausea and vomiting as it's on its own. It's not very emetogenic, but of course in combination with something like cisplatin, we treat it as a highly emetogenic regimen, so patients will need prophylaxis for those few days after. Okay, so we'll do our first patient case. So this is MS. He's a 62-year-old male, and he's been diagnosed with limited stage small cell lung cancer. And so he's going to start chemotherapy with cisplatin and etoposide, and it's going to be in combination with radiation. He has a past medical history significant for hypertension managed with amlodipine. He does have depression with anxiety and is on sertraline 100 milligrams daily. He has a 20-pack-year smoking history. And these are some of his baseline labs. As you can see, they are within normal limits, and the patient can proceed with chemotherapy today based on his ANC platelets and renal function. Alrighty, this is the dosing that he's going to receive. So typically for the small cell lung cancer regimens, we often give the cisplatin all on day 1 with a dose of etoposide, and then they get etoposide by itself on days 2 and 3. If you were to look in the guidelines, there's some variation on splitting up the cisplatin depending on the patient's status, but typically we give all of the cisplatin on day 1. And then we will repeat this every 21 days for 4 cycles, at least, while they're receiving radiation. But like I mentioned before with melanoma, I won't be asking about dosing. There's actually a bunch of different versions of this regimen. This is just an example of one that's seen commonly in practice. But I do want you to focus a little bit on the supportive care. So based on what we've talked about and what you've learned in the past about cisplatin and etoposide, what other pre-medications or supportive care medications would you like for Mr. MS to receive with chemo? Anything that you want him to take at home? And then what would you like to counsel the patient on, and then laboratory values to monitor while he's on treatment? So we'll take about 7 minutes to work on this and then talk about it. I think we'll go ahead and get started talking about the case. So I'll start in Augusta. What types of supportive care medications did you want MS to receive, the pre-medications with chemotherapy?
He's going to need CINV prophylaxis, probably with the quadruplet regimen. He's nervous.
Okay, great. So a quadruplet regimen for CINV prophylaxis. Can anybody tell me which drugs they picked, or what drugs they would pick for those 4? They'll go to Savannah if they selected their 4 drugs. Or if you did 3, maybe why? Not necessarily wrong, depending on where you look.
We did a triplet regimen because he was a male. We didn't really see other risk factors for a quadruplet. And we did ondansetron, dexamethasone, and olanzapine.
Okay. So the question of whether or not to use olanzapine comes up every once in a while. We've not adopted it here at the Georgia Cancer Center across the board for all highly emetogenic chemotherapy. What I would say is you are right that the patient doesn't have a whole lot of other risk factors. So female, younger patients, patients that have a history of motion sickness or morning sickness, and no alcohol use are the higher risk patients. But him having cisplatin is probably the most, it is the most important risk factor. So he's still pretty high risk. As far as a triplet, if you were to do a triplet only, and you were to use that regimen, technically the study that looked at olanzapine with a 5-HT3 and dexamethasone used palonosetron, which does have a longer half-life, is probably maybe a little bit better for delayed nausea and vomiting than ondansetron. Though we do, in some patients that have a reason to not get amend or fosaprepitant, we have done the ondansetron combination just from a cost perspective. But if you were to do a triplet, I think this patient would probably benefit quite a bit from an NK1 receptor antagonist with a 5-HT3 and dexamethasone. And I do like the 4 drugs. It's a lot easier to control it on the front end than it would be to add on olanzapine later, but that's often the pushback I get from physicians. Like, we'll just do the 3 first and then add the olanzapine later if they need it. But as you may recall from your CINV lectures, once a patient has a really bad experience, it's very hard to overcome that. They may develop a lot more anticipatory nausea and vomiting with subsequent cycles, and then you run the risk of having complications like dehydration. On top of them receiving something like cisplatin, it's a little bit easier to control it up front. So if the patient doesn't have a reason to not get olanzapine, I do agree with the 4-drug regimen. The patients that we struggle with a little bit giving olanzapine to are those that have a significant site history, where maybe they're already on some sort of dopamine antagonist, and so we'd obviously want to maybe avoid that in those patients. But depending on the guidelines you look at, some still have the triplet regimen as an option for highly emetogenic chemo. Anything else that anyone wanted to add as far as either with treatment or at the clinic, or anything for take home that the patient needs? and we'll go to Albany.
We would give them something for breakthrough nausea and vomiting.
Okay, great. So yes, definitely breakthrough medications at home. One kind of easy thing with this regimen is that if you're going to do the delayed nausea and vomiting on, say, days 2 through 4, this patient will be in clinic getting chemotherapy on days 2 and 3 as well, so you can add some pre-meds to the etoposide. But they may need something for that day 4, especially if you selected the quadruplet with olanzapine, that should be through days 1 through 4. But also, of course, some breakthrough medications as well is very important for patients to have, and then to also be kind of counseled on how to use them, to be a little bit more upfront and aggressive about using it and using them earlier rather than later. Some patients, when you start talking with them about chemo, they expect to be sick, so they think that nausea and especially vomiting is normal with chemo, especially maybe older patients that had a family member a long time ago that received chemo that had a lot of trouble with that. But I do try to emphasize to them that we actually are very good at preventing this now. So if they're actually throwing up at home, that is not what we want them to be doing. So we need to do something differently if that happens, and to try to use their breakthrough medications earlier and often if they need them, and just kind of keep us up to date on how it's going at home, so that way we can make adjustments on subsequent cycles. And as I mentioned, with cisplatin, if you look in the package insert or a reference like Lexicomp, it does recommend significant IV hydration and oral. So if you have a patient that's able to take in a lot of oral hydration, they can do that as well at home, but we typically will still give them a couple of liters of fluid between their chemotherapy and pre and post hydration when they come in to kind of help them get started, and then encourage them to drink a lot at home. Occasionally you'll have a patient that's really not able to do a lot of PO. As you can imagine, if someone's very nauseous, then they're maybe not able to drink enough at home, so adding on IV hydration during their cycle may be helpful. We use a lot of cisplatin for head and neck patients as well, and so they'll often have a PEG tube in. So depending on how well they're tolerating that, they tend to get a lot of radiation to the neck. They may not be able to swallow at all, so it's important to kind of keep up hydration with those patients and assess whether or not they can actually swallow anything, and if they can't, then making sure to set them up with IV hydration. So definitely something to counsel patients on, make sure they know that they should be drinking at home. Some patients need a log to kind of help keep up with about 1 to 2 liters for the few days after chemo, and make sure that they're doing a good job with that. And then in Athens, what about lab values? What would you like to monitor with this regimen, maybe on the next cycle?
We said renal function, hemoglobin, Chem7, CBC with diff, baseline audio test, and EKG at baseline.
Okay, great. Yes. All of those sound very appropriate. The one other thing I do want to mention with, and it may not have been on the slide, I'm going to double check. It wasn't on this slide, but something to keep in mind along with the nephrotoxicity with cisplatin, it does cause patients to waste a lot of electrolytes, particularly potassium and magnesium. So definitely making sure to get the chemistry and check their electrolytes. It's not uncommon at all for patients to need supplementation for those. In fact, a lot of centers will just add magnesium and potassium to the fluids we give them on the day of treatment to just kind of account for the wasting that we know will happen with cisplatin. So making sure to keep track on those electrolytes. If patients need some PO at home, that may be helpful. And then, of course, monitoring for ANC, platelets, on subsequent cycles, renal function, etc. So those are all great. All right. So, sorry, I thought that was a question, but it was a question. So that's about it for small cell lung cancer. There's a lot more to it once a patient kind of progresses through first-line therapy, but we don't really have a good option for what to do after, and all of the response rates are pretty low. So I do for these, there's a lot of different treatments for these two types of cancer, so we're just focusing kind of on the first-line therapy, but just keep in mind those pertinent counseling points and supportive care recommendations for those regimens. And we're going to talk a little bit more about immune checkpoint inhibitors, but when it comes to adding that along with the carboplatin and etoposide for extensive stage, all of those same side effects that we started talking about with melanoma, we'll go over again, apply to that regimen as well. So, but we're going to switch gears now to non-small cell lung cancer. So this is kind of a basic introduction to treatment. There's a lot of variation in what you can do depending on the patient's stage, their comorbidities, their specific subtype of non-small cell lung cancer. I will say though, as I mentioned, we're going to focus on first line, and we're actually going to focus on metastatic. There's a lot of interesting things to learn about stages 1 through 3, but just for the purposes of time and making sure we cover kind of the more unique aspects of non-small cell lung cancer that you may not see in other types of cancer, we're going to focus on stage 4 or metastatic patients. And we're going to talk about the chemotherapy first that we use, because there are some medications that you'll really only see in non-small cell lung cancer. So in patients who have stage 4 or metastatic non-small cell lung cancer, a chemotherapy doublet, kind of like the small cell lung cancer, has been the standard of care in a patient with a good performance status. So that means someone with an ECOG score of 0 to 1. In case that's not been reviewed a lot in class, you'll hear a lot about performance status, and this is basically a way to see how much of a patient's daily activities are they able to complete, and how limited are they by their diagnosis. So a patient that is able to get up, do all of their ADLs, so this would be, they're able to bathe themselves, do laundry, dishes, cook food, go to the store. Those are the patients that kind of fall into a 0 or 1 category, depending on if they get a little bit more short of breath than they used to, et cetera. But a patient that's spending up to 50% of their time in bed, or more than that, is when you start getting into those higher performance status scores of 2 to 4, and those are not patients that are always eligible for the full regimens that we would recommend, because we may do more harm than good with that much chemotherapy. But we'll focus on patients that are a good performance status, so these would be 0 to 1. And it's been a chemotherapy platinum-based doublet for quite a while, but similar to what I mentioned with small cell lung cancer, there have been a lot of studies in the last couple of years looking at adding those immune checkpoint inhibitors to that chemotherapy as first line. And patients do live longer if we do that. So if they're eligible to get the chemotherapy with an immune checkpoint inhibitor, that is the preferred first-line option for non-small cell lung cancer as well. There are certain medications that a patient may be eligible for depending on their particular type of non-small cell lung cancer. So we have, broadly speaking, either patients who are squamous histology, or everything else, which is non-squamous. And those patients that are non-squamous are able to get a medication called pemetrexed, so we'll talk about that in a little bit. But it is not something you'll see too often in other cancers. If it is used elsewhere, it's usually a much later line in therapy as a salvage option. But for non-small cell lung cancer, non-squamous histology, that is the preferred medication to use. And typically, they, as I mentioned, will get a platinum-based combination, so it would either be cisplatin or carboplatin. And then it's in combination with one of these other medications. If they're non-squamous, it's pemetrexed. If they're squamous, then it's usually one of the taxanes. So we'll talk about those a little bit as well. These are the most common first-line options. If anyone is excited to look through the non-small cell lung cancer guidelines and you go to systemic options for metastatic disease, there's easily 20 of them listed, and they're all category 1. The reason for that is the way NCCN kind of assigns their recommendations as category 1, which is the best category that you can get, is whether or not the primary literature showed a survival benefit. So a lot of these regimens have been evaluated a long time ago, and they were better than whatever we were doing before. But really, now they will denote a preferred category 1, and these are the ones that, for right now, are the preferred options for first-line therapy. So very commonly, we will do carboplatin, pemetrexed, and pembrolizumab, and that is for non-squamous non-small cell lung cancer. If a patient has squamous, then they can get paclitaxel instead, but everything else kind of stays the same with carboplatin, paclitaxel, and pembrolizumab. You can use cisplatin in either of these, but a lot of the times what I see providers tend to use is carboplatin because it may be a little bit better tolerated. And there wasn't really a difference in the studies, but it's not wrong to use cisplatin either, but really adding that immune checkpoint inhibitor has been kind of the big change for these patients. So just to review a little bit about carboplatin again, similar to cisplatin, it is that platinum agent that interferes with DNA function. There are some toxicities that are a little different with carboplatin. As I mentioned, there are some patients, if you have someone with stage 4 non-small cell lung cancer and you can choose between carboplatin or cisplatin, it does tend to come down to the side effects a lot of the times as to which one we select. So carboplatin is not as emetogenic as cisplatin. It's dose dependent, so if you look back on this slide, our AUC is typically 5 or 6 in these regimens, so that is considered highly emetogenic, but depending on which guidelines you look at, you may not necessarily need to do a quadruplet therapy and may be able to do triplet for CINV, but it may be a little bit less emetogenic than cisplatin. We don't have as much of the nephrotoxicity or ototoxicity issues with carboplatin, so that's a benefit. It may not have as much of the electrolyte abnormalities as far as wasting of potassium and magnesium, but it can still happen. Patients seem to develop, at least from what I have seen, more cytopenias with carboplatin, but we can usually kind of get around that with either dose reductions or adding something like GCSF. But it does seem to be maybe a little bit more myelosuppressive sometimes. It may also be what we're combining it with as far as how those trends kind of shake out. But one toxicity that is more common with carboplatin than cisplatin are the hypersensitivity reactions. With the platinum agents in general, it is an acquired hypersensitivity, so it tends to be with later cycles after repeat exposure. And we can manage it using desensitization protocols. Some providers prefer to switch someone if they can from carboplatin to cisplatin. There might not be a lot of cross-reactivity, but we tend to see that maybe a little bit more with carboplatin than with cisplatin. Peripheral neuropathy, I think the reported incidence for neurotoxicity may be a little bit higher with cisplatin, but we tend to combine carboplatin a lot with other medications that cause peripheral neuropathy, so this tends to be bothersome for patients as well. But just as kind of a summary of that, carboplatin tends to be a little bit better for the kidneys. It's less nephrotoxic and is dosed a little bit differently to account for a patient's renal function. So there's a benefit there if you have a patient who's either high risk for AKI or has baseline CKD, and may have less of the nausea and vomiting and electrolyte abnormalities than cisplatin. As I mentioned, pemetrexed is kind of one that's a little bit unique to non-small cell lung cancer, at least in the first line. It is an antifolate, so this is similar in mechanism of action to methotrexate that you have hopefully reviewed on previous lectures, but the way we dose it and manage toxicities is very different, but it is kind of in that same class of chemotherapy. For toxicities, the two unique ones that I want to point out are skin rash and anemia. So pemetrexed does require pre-medication for a patient to do at home, and there are medications we have to give in the infusion center to help prevent both of these toxicities. When they first studied pemetrexed, they had actually quite a hard time with the anemia as well as skin rash and some other GI toxicity, and they found that patients were requiring, once they added in pre-medication with dexamethasone the day before, day of, and day after treatment with pemetrexed, the incidence of skin rash went way down, so that is a recommendation in the package insert to give patients dexamethasone pre-medication. And then the anemia and other dose-limiting toxicities drastically improved when patients were adequately supplemented with B vitamins, specifically folic acid and B12. So that helps to prevent a lot of those toxicities. which kind of makes sense if you think about this being an antifolate. So patients are, it is suggested to start a folic acid supplement at least a week before starting pemetrexed, and they should receive intramuscular vitamin B12 every 9 weeks while they're on pemetrexed as well. So that is something to make sure to educate patients on, that they understand to take their folic acid every day. There's a range in the package insert as far as dosing, but to make things easier and allow patients to get a prescription, we tend to just prescribe the 1 milligram once a day. And we prefer to do it that way instead of having them take a multivitamin, just because you want to make sure they're selecting the appropriate dose, and that they're understanding that this is something a little separate specifically for their chemotherapy. So we found it to be a little bit easier to just prescribe the 1 milligram of folic acid. And then the B12, we try to line up with their treatments and give it to them while they're in clinic. But this has really helped to improve the tolerability of pemetrexed. These other side effects are a little bit more nonspecific and tend to go along with cytotoxic chemotherapy, neutropenia, nausea, vomiting, fatigue, especially in combination, with the platinum agent. But definitely a unique aspect of pemetrexed and something to remember for practice as well as for the exam is that it does require the pre-medications with steroids and folic acid and B12. And we'll focus on paclitaxels. We tend to use this a little bit more commonly in the first-line setting. I mentioned docetaxel is an option for some patients, but some of the toxicity is a little bit similar. So this is one of our taxane medication that acts in the late G2 mitotic phase of cell cycle. The toxicities, when patients in this particular regimen of carboplatin with paclitaxel, if they lose their hair, it's most likely due to the paclitaxel, so it can cause a lot of alopecia. This medication is going to come back up when you learn about breast cancer, because we use a lot of the taxanes there, and that's a lot of what causes the hair loss. It is moderately emetogenic, so some patients do have a lot of nausea, though this medicine is not typically used by itself for long periods of time. There are some indications in breast cancer after their initial treatment, but at least for lung cancer, it's typically in combination with a platinum-based agent, so that's also where a lot of the nausea comes from. The peripheral neuropathy with the taxanes is one of the most troublesome side effects with these regimens, and that's why it seems like sometimes we have a lot of peripheral neuropathy with carboplatin, but these two medications tend to go together for a lot of different cancers. So this is something that patients start to notice maybe after a few cycles. It is more of a cumulative dose effect, where maybe 3 or 4 cycles in, they start to notice that numbness and tingling. And there are different agents we can use to help treat that. And we won't go into a whole lot of that right now, but it is something to make sure to educate the patient on, something to consider when you're looking at a patient at baseline prior to them starting therapy with paclitaxel. Do they have other comorbidities that might increase their risk for peripheral neuropathy, especially diabetes? Some patients come into clinic and they're already on something like gabapentin, so it's always kind of worth asking, what is that for? Because if it's for neuropathy, there's a chance they may need to modify their treatment for that. Hypersensitivity reactions are also relatively common with the taxanes. Unlike the platinum, this is most highest risk on the first and second doses, so typically in the first infusion. So patients do require pre-medication for their, especially their first few cycles, so we tend to put it on for all of them. With things like an H1 antagonist, H2 antagonist, steroids to help prevent the hypersensitivity reaction. You'll see in some centers they have patients start the high doses of steroids the day before paclitaxel to try to help with that. One thing that can be a little tricky with is adherence. We tend to do IV steroids the day of just because it's a little bit easier on patients and we don't have to rely on them taking the medication the day before and taking it correctly. But what this will feel like for patients in general with a hypersensitivity reaction, what I try to counsel them on is that they need, it'll feel somewhat like an allergic reaction. So some patients will get shortness of breath or flushing. If it's a severe reaction, they may have difficulty breathing. And we manage it in this case with, for stopping the infusion, they'll get infusion reaction emergency medications via IV. And once the reaction has resolved, you usually can resume the chemotherapy at a slower rate. And that helps to get them through the first dose. And with paclitaxel, once they've had several doses of it, their risk of reaction goes way down, even in patients that have reacted in the past. They're usually able to tolerate it on subsequent cycles. So, but it is something that when looking at orders for a patient receiving paclitaxel, they should have those additional infusion reaction prophylactic medications such as Benadryl, famotidine, or ranitidine, depending on institution preference, and then steroids. All right. So we'll practice a little bit looking at a patient getting one of our preferred first-line options. So this is JB. She's a 55-year-old female. She has stage 4 adenocarcinoma of the lung. So this is a type of non-squamous, non-small cell lung cancer. And so based on that, she's going to get carboplatin, pemetrexed, and pembrolizumab. All of these are given through IV on day 1, and the cycle's repeated every 21 days. And so for JB, based on what we've discussed with these medications, what would you like for the patient to start either prior to chemotherapy or the day of treatment? And then what are some key counseling points about these medications that you want to make sure to discuss with her? We'll take a few minutes to do that. Alrighty, so we'll start talking through this patient case a little bit. So I'll start in Albany. Any medications that you recommend that the patient start either prior to treatment or receive on the day of treatment?
The dexamethasone and folic acid and B12.
Okay, great. Yes. So this patient is receiving pemetrexed. So it'll be important that they start the folic acid, and they should also receive their first dose of B12 at least a week before pemetrexed. But definitely making sure that those get started, and then telling the patient about their dexamethasone, which they will start the day before treatment and take for 3 days. In Augusta, any other medications that you would like for the patient to receive on the day of infusion?
On day 1, we would want to start triplet therapy for prevention of nausea.
Okay, perfect, yes. So the carboplatin with an AUC of 5, so if the dose is an AUC of 4 or higher, the recommendation is to treat it as if it's highly immunogenic. Often we will do a triplet therapy. Sometimes the question is, if they're taking dexamethasone at home, do you have to give it to them on the day that they come in for treatment? Usually we don't, as long as they took it. If the patient for some reason forgot or didn't take it, which this happens all the time, then you can give them the dexamethasone when they come in, and then just have them do it the day after to help with the rash prevention. But even though the dose is a little different, which you don't necessarily need to know the dose of dexamethasone, but because they do it for the 3 days, that's usually sufficient for CINV as well. And so typically we will also give them something like fosaprepitant and then a 5-HT3 antagonist. Do they need any prophylactic medications for an infusion reaction? Question's a little tricky, but technically no. The carboplatin, the recommendations for the platinums is that they do not need to receive pre-medication for infusions. That would be more for paclitaxel. Patients can have an infusion-related reaction, but we don't, the routine pre-medication with infusion reaction prophylaxis doesn't seem to help as much with the platinums because it is more of an acquired hypersensitivity later on in treatment, or if they're re-challenged later on. So it doesn't seem to really reduce the incidence enough to warrant giving everybody prophylaxis. But if this patient were receiving paclitaxel instead of pemetrexed, then they would need medications to help prevent infusion reactions. And then are there any counseling points that anybody would like to add? So making sure the patient takes their folic acid and dexamethasone at home, the nausea and vomiting and infusion reactions. Anything else that someone would like to talk with them about? And we'll have Savannah answer this one.
We can monitor for neutropenia.
Perfect, yes. So just want to make sure, I know sometimes it gets, when we talk about these drug-specific side effects, just to remember, of course, that patients are at risk for febrile neutropenia with these regimens. This one in particular is not a high-risk regimen, but it is still possible that the patient will develop a fever at some point. Neutropenia is possible with this regimen, so just making sure to counsel patients on if they develop a fever at home, what to do from there, and follow the recommendations for management of febrile neutropenia. Okay, so before we move on to targeted agents, I know it's a lot of information. What questions do you have? And I think I'm going to see, I'll make sure the slides get posted today for these.
I have a question in Athens. With regard to preventing electrolyte abnormalities, is it beneficial or is it common practice to give the patient some sort of like a lactated ringers or like a Fragmilite during a chemotherapy day?
So that's a good question. So whether or not we can help prevent the electrolytes with a different type of fluid rather than, say, normal saline. So the recommendation is actually if we're talking about cisplatin in particular, to use a saline-based fluid because the salt content helps the patient to diurese better, and they're able to actually excrete the cisplatin better. So we actually try to avoid other fluids and use normal saline for more of the forced diuretic component that you can get with normal saline that you may not get with the sodium content of other fluids. But we will typically add specifically potassium and magnesium to the IV hydration on the day of treatment, pre and post, to help accommodate the wasting that we know will occur with cisplatin. And then some places use diuretics as well to help that diuresis process. It's a lot of conflicting literature on whether or not that's needed, but specifically, you may go to a cancer center, and we were doing it up until a shortage recently, but where I did my PGY2, we didn't do it for anybody, but some places will add mannitol to the cisplatin for that same concept of helping to force diuresis during treatment. A lot of places will use more like a PRN Lasix if the patient is not urinating enough during treatment, because they end up getting probably 2 to 3 liters throughout the chemotherapy day. So they should be going to the bathroom quite a bit, and if they're not, then having the Lasix as a PRN option helps. But we will typically just add the magnesium and potassium to the continuous fluid that they get during treatment, as opposed to using something like lactated ringers. But good question, thank you. All right, so I just want to make sure so that there's no anxiety about, like, say, for the exam. So with something like this, when you're posed with like a patient case question on the test, I will provide you, when it's something like this, like with the actual regimen, and ask more of the supportive care type questions. Bless you. There may be some questions when we talk about these targeted agents where it's more selecting the medication, but I'll explain in a little bit, not necessarily as hard as it sounds, but typically with this type of question, I prefer to present you with what treatment the patient will be on and focus on supportive care. So at least if you were to come through my rotation in Augusta, that's what we would focus on more as a student, and what I think the majority of pharmacists will see is more the supportive care side rather than having you pick between one of 20 different options. That can be hard anyway. So, alrighty, so we're going to move on to the targeted agents, and I know some of this was in the pre-class lecture, so as just a review, one unique aspect of non-small cell lung cancer is that we do have some specific mutations within the cancer cells. Kind of like with melanoma, testing for that BRAF mutation, we have driver mutations for non-small cell lung cancer as well. And similarly with the BRAF mutation in melanoma, these are the mutations that we have identified within the cell signaling of the cancer cells that causes that increased cell proliferation. So the thought being, of course, if we can have a targeted drug that turns off that particular mutation in that cell pathway, that we can stop cancer growth and kill the cancer cells. And these actually do work very well. Some patients are on these medications for years at a time before they have any kind of disease progression. It's more that these mutations overall are not that common, and they are usually mutually exclusive, meaning someone won't have both an EGFR and an ALK mutation. It's going to be an either-or scenario. The most common mutation that we see in driver mutations for non-small cell lung cancer is the EGFR activating mutation. As you can see, overall, it's 10 to 15% of non-small cell lung cancer. In patients of Asian descent, though, it's present in up to 50% of patients. And typically, it's never or light smokers, which is the case for most of these driver mutations, with the exception of the BRAF mutation. And then here I have listed all of the EGFR targeted medications that are available and FDA approved. These have been kind of FDA approved over a course of time, so we do have a preferred option based on those recent studies, but just keep in mind that there are some patients, erlotinib was our first one, and so there are occasionally still patients on erlotinib because they've just been responding for 4 or 5 years. So it's not uncommon to still see people on these medications, but a new diagnosis would likely be started on a different option. The ALK mutation is less common. Still never or light smokers, and we have lots of options there. And then ROS1 is a very similar mutation to ALK, so that's why some of the drugs are repeated. And then, of course, our BRAF V600E mutation, this is the same mutation we talked about in melanoma, so it does have the same drugs. Dabrafenib and trametinib is the only combination that's actually been studied in non-small cell lung cancer. So even though we have all those other options for melanoma, this is the one that has the recommendation in lung cancer. And if a patient can't tolerate both medications, you can do single agent, either dabrafenib or venurafenib, but ideally, same as melanoma, if they can tolerate two, we would rather them be on the combination. And this is just that summary slide on what the different mutations mean and how they are acting as a driver mutation for non-small cell lung cancer and kind of what pathway they're upregulating. But I would focus on more which medications fall into which mutation. So as I mentioned, there may be a question or two as far as like selecting a targeted agent, but I wouldn't have you select, it would be an EGFR positive patient and then have it be all EGFR mutated drugs and you have to pick which one is best for the patient. It'd be more like there's one that's an EGFR drug and maybe one that's an ALK inhibitor and then dabrafenib and trametinib. So more just kind of try to remember which ones are associated with which mutation, and that there is the overlap between ALK and ROS1, but I won't try to trick you and throw in one of the ALK drugs that is not used for ROS1. I promise I'll try not to be too tricky, but just kind of, I would focus on which ones fall into which class. Okay. So we'll start with the EGFR mutated non-small cell lung cancer. So these are the 5 drugs that are currently FDA approved. And I have folded the one that is preferred in the NCCN guidelines, so that's osimertinib or Tagrisso. A nice benefit for all of these is, unlike the drugs we've just been talking about, these are all oral agents and they're all once daily continuous options, so these are very convenient for patients. And like I mentioned, if a patient has this mutation, they tend to respond very well to these drugs and can be on them for a long period of time. Some patients have to stop due to toxicities, but a lot of times we'll see patients on these for a few years before there becomes an issue. The reason osimertinib is now a Category 1 preferred option, this is actually a change within the last year or so. This used to be what we would put people on if they progressed on the other EGFR inhibitors, but they did a study looking at this in the first-line setting compared to some of our older options like erlotinib, and the overall survival was better. And so this is now our preferred option. It's good to kind of just be aware that there are these other drugs available, though, because you may have patients that were started on one of the other EGFR inhibitors prior to osimertinib being available, and so then kind of knowing what we would do after is helpful, but that is something I'd refer you to the guidelines too, because there's some mutation testing. But osimertinib is our preferred category 1 option for patients with an EGFR mutation. The EGFR tyrosine kinase inhibitors, or TKIs, are unique in their toxicity profile. So the most common toxicity that we see and that patients complain about are the dermatologic toxicities, and this has to do with it being the epidermal growth factor receptor. And so there are obviously a lot of EGFR in different areas of the body in skin tissue. So patients tend to have these toxicities. They, excuse me, are more common with some of our older EGFR TKIs, but it's something that we try to counsel all patients on, even with something like osimertinib, where it's maybe not as common. But it is possible that they will develop this macular or papulopustular rash. And this is just a picture of a common EGFR related rash. This will come up again when we talk about colorectal, because we have some IV EGFR inhibitors that have these same toxicities, so just make sure to keep these in mind. But it tends to be on the face and chest, and can be very bothersome for patients. One, they don't like the way it looks, but rarely it can get extremely severe and be a source of infection. They can have hair changes. It's not typically necessarily hair loss unless they're having like a skin irritation on the scalp, but they can notice maybe some hair thinning or changes in texture. And then patients can also develop mucositis or mouth sores. We have a lot of options for EGFR toxicities, dermatologic toxicities. So this is definitely something to keep in mind and counsel your patients on if you see someone starting or has been on this medication for a little while. There are some supportive care, non-medication recommendations we can make, such as making sure to use lukewarm rather than really hot water when they're washing their skin. Trying to use soaps that are meant for sensitive skin, avoiding a lot of those perfuming agents. Something that isn't too drying. If they can avoid, say, shaving their face, if at all possible, that tends to help. And then blow-drying hair can really irritate the scalp with the very hot air. So things like that, making sure to dab their skin dry instead of rubbing with a lot of friction, all help to kind of prevent that issue or making it worse. They should wear sunscreen with at least an SPF of 25 when out in the sun. And then we do have some systemic agents that we can use as prophylaxis. Namely, it's minocycline and doxycycline. You may recall these if you've had like a dermatologic part of your pharmacotherapy, that we do use these for certain skin conditions. We use them for acne, things like that. So this presents very similarly to that. This is an option. We don't always do it with the oral EGFR TKIs, especially the newer ones like osimertinib. May not really need somebody on prophylaxis from the get-go, but if they develop a rash, this is definitely an option. When we talk about the IV EGFR inhibitors in colorectal, there are some recommendations for prophylaxis in patients up front, but those are typically the drugs that we will use. All right, so we're going to go on to patient case 3. So this is LM. He's a 48-year-old male, and he is coming for treatment planning for stage 4 adenocarcinoma of the lung. As a side note, these mutations, and I may have put this in the initial presentation, these mutations do tend to be more common in non-squamous non-small cell lung cancer, which includes adenocarcinoma. It's not impossible for someone with squamous cell lung cancer to have one of these driver mutations, but we don't necessarily test for it up front because it's a lot less common. So these will also typically be non-squamous non-small cell lung cancer. If a patient has a driver mutation, this question comes up sometimes, whether or not to use the driver mutation targeted agent or do we use chemotherapy with something like pemetrexed. You are supposed to use the driver mutation first, the oral targeted agent, because we know that that's kind of the cause of the cancer. Occasionally, if a patient can't wait for mutational testing to come back, you'll see someone started on cytotoxic chemo, but then often they'll be switched. However, these patients are usually not so acutely ill that they have to start treatment before we know the mutation status, and we've gotten a lot better about getting those results back quicker. So usually patients are able to wait and then they can start on one of these targeted agents, as opposed to chemotherapy. The patient's past medical history is listed here, and he does have the EGFR mutation, so the physician is deciding to move forward with osimertinib 80 milligrams daily per the recent guideline update. So just based on what we talked about, are there any other options that you would consider for this patient, or is this what you would like the patient to start on as well? And then what are some counseling points for this medication? And then as far as monitoring parameters, I would look in either the Tagrisso package insert or in the Lexicon monitoring tab to see if there are any other things beyond baseline, kind of our basic labs that we get for patients that we should be doing for a patient starting on osimertinib or another EGFR TKI. So we'll take about 4 minutes or so to do this. Alrighty, so in Athens, were there any other medications that you would want to use, or are you in agreement with osimertinib?
We are in agreement.
Okay, good. Yes, so as I mentioned, a relatively recent change, but osimertinib is the preferred option for patients with a new diagnosis of an EGFR mutation for non-small cell lung cancer. There are different recommendations if the patient is already on one of the other medications and then have disease progression as to what you do next, but just keep that in mind. And then here in Augusta, what counseling points do you have for your patient starting osimertinib, and then any monitoring parameters that you recommend?
Wear sunscreen.
Yes, so wear sunscreen. So yes, a lot of the dermatologic toxicities are definitely something worth counseling about. It's also an oral medication, so going over that is once a day. There's not really any special storage like we saw with trametinib, but otherwise definitely a much more convenient option. Did anybody find any other monitoring parameters that they wanted to check before starting treatment or during treatment?
Heart.
Oh, sorry, what was that?
Cardiac things.
Yes, so cardiac function. So there was it's a small percent, but a small percent of people in the clinical trial for a lot of these trials for osimertinib did develop cardiomyopathy and a reduction in their EF. It's not quite the same mechanism, kind of like what we talked about with dabrafenib and trametinib. It's not the same as an anthracycline, but it is something that it's recommended to look out for. So typically patients should at least receive a baseline echo before starting this medication. As far as how strict people adhere to any subsequent echoes, it kind of depends on someone's risk factors, whether or not they're developing signs or symptoms. It's pretty rare, but it's good to know someone's baseline cardiac function before starting. Yes.
Is that more associated with the certain neurodependency, is that right? Like, if they have baseline heart risk factors, would you choose?
We can't hear them.
Oh, sorry, I'm going to repeat the question. So the question was whether this is more common with osimertinib than it is with some of the other EGFR TKIs. I think, so cardiac toxicity with the targeted drugs is a little, it's interesting how it's been reported. I think it's something that as we've used them more and more often, they have become more attuned to needing to monitor for it. I would actually have to go back and look at whether or not something like erlotinib has a recommendation for a baseline echo. I think it's a small incidence, but it's something that can happen with any of the EGFR TKIs in particular. So it's not necessarily something to avoid osimertinib for. That was the second part of the question, was whether or not if someone has a significant cardiac history, if we have to avoid the drug, or if we would use another one. The newest option on the list is actually not one I've seen much, and it was only really relatively recently approved, is dacomitinib. So I don't know if that one has any benefit from a cardiac toxicity standpoint, but osimertinib has a lot of benefits as far as whether or not someone has brain mets. It passes the blood-brain barrier a little bit better, so sometimes it depends on the risk and benefit of treating their cancer, but I don't know if erlotinib has a baseline recommendation, just 'cause it's an older drug, so I don't know if it was as widely recognized if it caused the same incidence, because it's a pretty small one for osimertinib. I think it's under 5%, but we're a little bit more cautious about these things now as opposed to when some of these drugs were first approved. But I can find out more.
So generally that one's preferred though? There's not
Yes, so
like a-
generally the question is what if there's a reason to not use it. Generally, no, we typically will use the osimertinib, and hopefully, I've not had a patient say get diagnosed with EGFR, non-small cell lung cancer, and also have like an EF of 20%. And what do we do after that? That's a good question. If there is one that has maybe a little bit less cardiotoxicity, but a baseline dysfunction, how much worse it will make it, I'm not entirely sure. I think in the trial they enrolled people with adequate function, so it's hard to know. But overall, though, they have a very similar toxicity profile, and it would be preferred to use osimertinib. Alright. So you have kind of a similar story with ALK-mutated non-small cell lung cancer. There are several options, but alectinib is also the category 1 preferred option. And in this particular trial, it was compared to crizotinib, which was our kind of gold standard first-line option. It was similar to erlotinib, the first one that was approved. And patients had superior progression-free survival when compared to crizotinib when they received alectinib, and similarly to osimertinib in patients with brain mets, alectinib crossed the blood-brain barrier better, and so those patients did better receiving that medication. So it used to be used as a subsequent line option following crizotinib, and has now been kind of moved up to the front line. So we'll kind of go through this. I'll kind of talk through how I would approach this question, because this happens a lot if you're on a teaching service, or if you were to come and do rotations, say at the Georgia Cancer Center. We often have our fellows rotating through clinic, and so this is an opportunity for them to learn about all these drugs as well. This is a fellow rounding in the lung cancer clinic and unsure about what agent to select for a new patient with stage 4 non-small cell lung cancer, ALK mutated. So this comes up quite a bit. These guidelines have changed a lot in the last year and a half or so. I think the number of modifications that were made just from 2018 to 2019, it's a lot of different versions. So sometimes the fellows in particular have a lot of things that they're needing to learn and kind of keep up with. So it's a great place for pharmacy to keep them abreast of all of the new trials that have come out and new abstracts that are available from these different conferences. So in this case, alectinib would be the preferred option. And then as far as looking at the different, it is a oral medication. There's the dosing, they would expect you to kind of help them, guide them through how to prescribe it. Drug interactions, common toxicities, and then monitoring for the next lab appointment. So I'll provide some answers to these questions. I want to make sure we go through all the immune toxicities, but the ALK inhibitors in general, one of their toxicities that can happen is actually bradycardia. So that can be more of an issue with crizotinib than some of our later generation ones, but to the point where some patients have needed a dose reduction. So it's more, they tend to not have a lot of drug interactions. They're usually not metabolized by CYP3A4 and all of that, but some patients may already be on something like a beta blocker, so more counseling your patient that there's the potential that starting this medication may drop their heart rate further, and that if they just kind of keep an eye on whether or not they're dizzy, feel like lightheaded when they stand up, and if they check their pulse every once in a while at home. Though it's not something we run into that's a huge issue a lot of the time, but something more when looking at your patient's current med list that they should be mindful of. All right. And then for ROS1 mutated non-small cell lung cancer, some of the same drugs, so crizotinib and ceritinib, are the two options that have also been studied for ROS1 mutation. It's a very similar mutation. There's some subtle differences, but that's why some of the drugs can be used either or. These are the ones that just have data, and crizotinib is the preferred agent. This option is actually a twice daily medication with or without food. but patients actually report a decent amount of nausea with this medication. And then there, as I mentioned, is the bradycardia. The visual disturbance is something more for crizotinib than the other drugs in this class. It tends to peak in the first couple of weeks and usually gets better. Usually patients have like a hard time adjusting from light to dark. They may notice some blurry vision. If it's anything severe, then they should be referred to an ophthalmologist to make sure there's not another cause. But it typically will occur early in treatment and usually gets better after. So it's just something to kind of prepare patients for. But if it's really bothersome or they feel like there's any kind of vision loss, then that should be evaluated right away. But overall, these drugs are well tolerated. And as I mentioned, there are patients that can be on these for years and they have very good response rates. So sometimes it seems like a lot of toxicity when you're going over it with a patient, but when compared to, say, traditional chemotherapy, patients tend to do really well. Okay, so we're going to go back to our immune checkpoint inhibitors. This slide has the 3 that we have currently FDA approved for metastatic non-small cell lung cancer. There's a 4th immune checkpoint inhibitor that we use for stage 3, but we won't talk about that medication. As you can see, for pembrolizumab and nivolumab, it's the same dosing as melanoma. So we do have that benefit of having flat dosing for all indications when they're used as monotherapy. Just recall that if you're going to use nivolumab in combination with ipilimumab, it's usually weight-based and is specific to indication. But we're going to focus on monotherapy for the immune checkpoint inhibitors. Pembrolizumab has multiple approvals, so it's approved in the first-line setting in combination with chemo, like we discussed. In patients that have a high PD-L1 expression, which is greater than 50%, and that's this 3rd bullet on this slide, patients may be eligible to just receive pembrolizumab in the first-line setting and not get the chemotherapy along with it. And then in patients who maybe have had a platinum-based chemotherapy before it was standard to use the immune checkpoint inhibitors up front, you have the option to use pembrolizumab as a second-line therapy. That is typically where we see nivolumab and atezolizumab as well, is in the second-line therapy. Nivolumab currently does not have an approval in the first line with chemotherapy, so it's usually after a patient has progressed on chemo. They can get this as a second line. Atezolizumab, same story where it's a second line option. There was a recent FDA approval with 4 drugs. I purposefully did not talk a whole lot about that regimen because we haven't used it much in practice, and it's kind of a very niche group that can get it, but it would essentially be bevacizumab with atezolizumab, carboplatin, and paclitaxel. The main barrier to that particular regimen will be cost. It's a very expensive regimen, bevacizumab. You'll learn a little bit more about it with colorectal. There's some other indications in gynecologic oncology, which we won't cover, but it's something you may see in practice. But it's very expensive and conveniently owned by the same company that makes atezolizumab. So they've reported their data in a way that makes it, they got that approval first as opposed to just atezolizumab. But, you know, gotta make the money somehow, I guess. But we'll focus on atezolizumab in the second line. Just know that if you see that, if anyone knows somebody with non-small cell lung cancer, that regimen comes up. There's a couple of patient populations that may benefit more, but I think we'll stick in practice to pembrolizumab with chemo as opposed to the 4 drugs. So we talked a lot about the dermatologic toxicities and colitis with melanoma. Those apply here as well. There were a couple of others I wanted to just mention while we're talking about immune checkpoint inhibitors again. Patients can get an immune-mediated hepatitis from these medications. And again, none of this is specific to disease state. This just kind of goes along with the drugs that you're using. And kind of the same story as before with melanoma. If you do use these medications in combination with ipilimumab, the incidence is a lot higher. But as you can see, about 1% of people who get just a PD-1 or PD-L1 inhibitor may develop hepatitis. It can be a delay to time of onset, about 12 weeks. If we're looking at our non-small cell lung cancer patients, they tend to be on the monotherapy. So it's something that may happen several doses in. But we do have to monitor their LFTs with treatment.
Dr. Saunders?
Yes.
Sorry to interrupt. Are you posting these slides?
Yes, I have sent Dr. Clemens the email, but I believe she's actually out sick today, so I was going to pop in the office over here and see if someone else can do it for you. So I apologize about that. So I'll make sure they get posted today though. And then when we talk about grading, so if this is typically manifest as an elevation in either their AST or ALT or their T-billy. And so if a patient develops grade 3 or 4 hepatitis, the recommendation is usually to discontinue the immune checkpoint inhibitor therapy permanently, but management is very similar to what we saw with colitis and the derm toxicities when it's more severe, is starting the high-dose steroids. So in a patient that has grade 3 or 4 hepatitis, you may have to go on the higher end of prednisone equivalents of 2 milligrams per kilo per day. There is some recommendations. We have a little bit more information about what to do if they don't respond to the steroids, but most patients will respond to the steroids. So they will also have that taper over at least a month. So same kind of information as far as toxicity management. Starting the systemic steroids of 1 to 2 milligrams per kilo per day, and then tapering over at least a month. And I won't ask you to grade hepatitis on the exam or anything like that. I'll let you know what the grade is if a question comes up about it. The other area that we see pretty commonly for toxicity from immune checkpoint inhibitors are endocrinopathies. So really in up to 30% of patients, they may have one or multiple of these. By far and away, though, the most common are issues with the thyroid, and particularly hypothyroidism, but it is possible to develop type 1 diabetes. So this would actually manifest more as your typical type 1 diabetic, where they then become insulin dependent. And I've seen it one time with single agent nivolumab in non-small cell lung cancer, so it can happen. Got admitted with a blood sugar of about 800. No steroids, no history of diabetes, ended up now on an insulin pump and everything. So this can happen. It's a very wide range of onset for time, but the key here are the second and third bullet points on this slide. So it may be permanent, meaning in that case of the patient that developed essentially type 1 diabetes, he will require insulin supplementation for the rest of his life. So it's not something that usually they regain function. If they develop, say, hypophysitis or adrenal insufficiency, they may require cortisol replacement. But it's usually something that we do not have to discontinue therapy for. So since this tends to be more of a hormonal supplementation issue, as long as we appropriately supplement whatever is missing, say it be insulin or starting levothyroxine, as long as we stabilize them, then we can usually resume treatment. So this tends to be the exception to the rule of the grade 3 or 4 toxicity, where it's a permanent discontinuation for most of these. In an endocrinopathy, as long as we're able to supplement them and stabilize their endocrinopathy, we can probably resume treatment after they are stable. So in the case of the patient with DKA, he obviously got admitted to the NICU, insulin drip. So once that all was stabilized and he was we found the right insulin regimen for him, working with endocrinology, he was able to later resume nivolumab without any issues. So it's kind of the exception to the rule, to just kind of keep that in mind. Hypothyroidism is a lot more common than hyperthyroidism, but it's very easy to manage. Typically with hypothyroidism, we just start levothyroxine, so luckily it's a very benign drug, and we do have a lot of patients that end up starting on it, and we don't usually have to stop therapy. So we'll just monitor free T4, TSH periodically throughout treatment. Once it starts trending, the TSH starts trending upwards, then we usually just start levothyroxine and kind of titrate from there. In patients with hyperthyroidism, you can manage as you normally would, which is usually symptomatic management with something like a beta blocker. We very rarely have to start someone on something like methimazole, but what we actually typically will see is initially a patient will develop hyperthyroidism because the thyroid gland becomes so inflamed, and then they become hypothyroid. So a lot of times, as long as the patient is not symptomatic, we like to just get a repeat and see if they're trending a certain way before we actually start systemic treatment. But typically patients, even if they develop hyperthyroidism, they'll become hypothyroid later and we start levothyroxine. So a very common toxicity, but something we can manage very easily. And then I did want to bring up pneumonitis. This is one of our less common toxicities. It's actually pretty rare. As you can see with the PD-1, PD-L1, it's 2 to 6%, but grade 3 or 4, 1 to 4%. There's some variation here because it will be a little tough to determine whether or not it's actually pneumonitis versus another issue, and that's why I wanted to bring it up with lung cancer in particular. So this is where patients have inflammation of the lung parenchyma. So they typically will present with these very non-specific symptoms. They'll be cough, they may have dyspnea, they may, because of all the coughing, have chest pain. The issue that we run into is if someone with lung cancer comes in with a cough or dyspnea, then there's a lot of questions you may want to ask yourself. Those patients, if they were former smokers or still currently smoking, which unfortunately happens a lot, it could be COPD. They often have some sort of baseline COPD, so whether or not this is just a COPD exacerbation. They could have pneumonia. These patients are very high risk for developing pneumonia and should be vaccinated, but often they're not able to complete their vaccine series before starting therapy, so they may not have been vaccinated. It could also be just their lung cancer progressing, so whether or not it's pneumonitis from their immune checkpoint inhibitor becomes a little tricky to determine. So usually imaging has to be performed in the setting of these symptoms to kind of rule out what's going on. Even that though, a CT may be able to differentiate between different types of lung toxicities they may be developing, but it tends to be this diffuse, like ground glass type opacity that they may see on imaging. As long as other infectious causes are ruled out, and you can pretty confidently say it's pneumonitis from an immune checkpoint inhibitor, the management is very much the same as it is for other immune checkpoint inhibitor toxicities, where you would hold the drug and start high-dose steroids. In grade 3 to 4 pneumonitis, this is where somebody maybe has very severe life-threatening symptoms. These are typically patients who have been admitted. They may even require intubation at some point, and that would be a reason to discontinue permanently. One note is that sometimes patients with pneumonitis require an even longer taper of steroids, up to 6 weeks. But typically in a grade 2 pneumonitis, it's still over at least a month. So nothing really new as far as how you manage it. Just kind of keep in mind that this can be really non-specific when it presents, especially if it's a patient with lung cancer. There's a lot of other questions that may have to be answered first before you just jump onto the high-dose steroids. And then another section I wanted to spend a lot of time on, because we didn't get to talk about this with melanoma as much, is the supportive care for patients on longer-term high-dose steroids. So we talked a little bit about in one of the patient cases that if a patient, say, has pre-existing type 2 diabetes or hypertension, those may get worse with the steroids, which is absolutely true. These patients are also at increased risk for infection when they're on high-dose steroids for longer periods of time. So I'm sure you've had a chance to maybe talk about infection prophylaxis in the setting of maybe hematologic malignancies and the drugs we would use in those cases. Some of that applies here as well if they're going to be on the steroids for a long period of time. As I mentioned with melanoma, these drugs are not immunosuppressive. The immune checkpoint inhibitors are not immunosuppressive in and of themselves, but if they're on high doses of steroids for at least a month, they're at increased risk, specifically for PJP pneumonia, because of the depletion of T cells that steroids can cause a lot of lymphocytopenia. So the guidelines for managing immune checkpoint inhibitor toxicities, if you're going to start a prolonged taper, that you may want to consider doing prophylaxis for PJP if they're on the equivalent of 20 milligrams of prednisone a day or more for 4 or more weeks. So this may not apply to every patient. If you're able to taper them off in that 4-week period, they may not be on that high dose of prednisone for that long, but it is something that if you're struggling to taper a patient off, because as you go down the dose, their symptoms recur, and you see that they're probably going to be on this higher dose of prednisone, then considering prophylaxis for PJP is warranted. What medications do we use for PJP prophylaxis? All right, so Augusto is a resounding Bactrim, so yes, that is our preferred drug. Of course, if you have somebody with a sulfa allergy, And as it can occur with some myelosuppression, they're not as common with the patients with solid tumors. But if someone has really low platelets and you're concerned because Bactrim can cause some myelosuppression, then we have other options such as atovaquone and Dapsone. But kind of the same thought process with HIV patients needing PCP prophylaxis, as far as Bactrim being the preferred option, it's the same here. And you can use very similar dosing. I know for oncology patients, we tend to do maybe a double strength tablet 3 times a week or twice a day on just the weekends, or a single strength tablet daily. But for HIV, because we're covering for some other things, it's a double strength tablet once a day. None of those are the wrong answer for this. It's more whatever works best for the patient and considering patient-specific factors. But Bactrim is our preferred option in this case. In patients that may be on high-dose steroids, so more than prednisone 20 milligrams a day equivalents, or equal to that for 6 to 8 weeks, then you may need to consider prophylaxing against a fungal infection. What antifungals have you learned about for prophylaxis? And I'll ask in Athens.
Echinocandins is
Yes, so echinocandins, there's a bunch of the azoles. I will say that these patients at baseline before starting the steroids are really not at an increased risk for an invasive fungal infection from their disease. So you'll see that with, say, someone with AML or receiving very myelosuppressive chemotherapy like induction for AML, that they are at increased risk of an invasive fungal infection and may need broader antifungal coverage. These patients, though, are usually fine, and then they start the steroids, and that puts them at increased risk. So fluconazole is probably plenty for them, and we are hoping that most patients are off of these steroids before 6 to 8 weeks. This would really be someone either with a very severe pneumonitis or some of the other more rare toxicities like there is the potential for cardiotoxicity, but that's very rare, where they need that really prolonged steroid taper, or in a patient that is, as you taper them, they tend to have their symptoms recur and they need to be continually prolonged on their steroids. But fluconazole is usually going to be enough for these patients, at least to start out with, and then if they're going to maintain the high-dose steroids or start having issues or fevers, then you can escalate from there. But just wanted to make sure to point out that difference, that some of our other indications for fungal prophylaxis, you need a lot more broad of an agent than fluconazole. You can also consider prophylaxis against zoster, so this would be with something like acyclovir. A lot of patients, these are usually older patients, so at some point they have been exposed to either zoster or HSV, and so the potential for an outbreak during immunosuppression with the high-dose steroids is possible, and a lot of these patients have maybe not quite received our fancy new Shingrix vaccine, so some of these patients were maybe ineligible prior with chemotherapy to receive Zostavax. So it's something to consider in these patients that they may want to be on acyclovir, but that depends on whether or not they've had a history of outbreaks or if you happen to have that type of infectious disease panel. A lot of these patients won't have that at baseline, of whether or not they have antibodies to or have been exposed to zoster or HSV, but something to consider if the patient reports it in their history. The guidelines also recommend either a PPI or H2 antagonist for patients at higher risk of gastritis, is how it's phrased in the guidelines. For those of you in Savannah, who would you think would be at higher risk of gastritis? It's kind of a tricky question, but so I think what you'll see in practice is a lot of physicians, as soon as they start the high-dose steroids, kind of no matter who the patient is, they will also try to start a PPI. If they're on 1 to 2 milligrams per kilo of prednisone a day, that may be very bothersome to patients, but the guidelines do specifically discuss patients that are maybe on other NSAIDs for whatever reason, if they're on chronic NSAIDs or taking aspirin, maybe for a cardiac indication, that they may be the higher risk for gastritis, and then our patients that are on systemic anticoagulation, say for VTE or AFib. Obviously, our oncology patients are high risk for VTE, so it's very common for them to be on anticoagulation. So in those patients, they may be the better patients when you start the steroids to also do either a PPI or H2 antagonist. Like I said, a lot of physicians will want to do it kind of regardless of those other risk factors and just because they're on steroids. In that case, I try to do at least the H2 antagonist and see how patients do, and then we can always escalate to a PPI later, but try to avoid all of that extra exposure to PPIs due to the long-term risks and side effects for PPIs, and then patients tend to, once they're on them, it's very hard to get them off. So that's a stewardship opportunity in these patients for pharmacists to kind of be helpful in deciding who is maybe higher risk for gastritis, or at least if we're going to do it for patients with the steroids, to try an H2 antagonist first. And then if they're on long-term therapy and they're on this amount of steroids, there is that risk for osteoporosis. So patients may need to have calcium and vitamin D supplementation. The patients can also have that like muscle wasting and just overall deconditioning with this high dose of steroids for a prolonged period of time. So if they're not getting all of that physical activity, they may notice a lot more weakness, which may also prone them to falls and things like that. So that's something worth looking at for particular patients, whether or not they can just do an over-the-counter calcium and vitamin D. You could even consider checking a vitamin D level if you would like to see if they are deficient and go from there. But a lot of times just having patients do the over-the-counter supplementation while they're on the steroids is more than enough. And it's not very clear when they say long-term therapy what exactly the guidelines are referring to. But really, if they're going to be on steroids for more than maybe that 4-week taper, it might be worth adding on for them while they're on the steroids. But the important things that I do want you to keep in mind from this slide is when prophylaxis would be required. So those patients on prednisone 20 milligrams daily or more for 4 or more weeks are the ones that may need the PJP prophylaxis. If it's 6 to 8 weeks of therapy, then they may need antifungal prophylaxis. You can consider acyclovir or some other type of prophylaxis for herpes zoster. And then the PPI or H2 antagonists for high-risk gastritis patients, and calcium and vitamin D supplementation. None of these are hard and fast rules, because there's obviously always going to be patient-specific factors as to whether or not you start these. But I think as we get better with managing the toxicities from immune checkpoint inhibitors, providers are getting a lot better at recognizing these toxicities and starting the steroids sooner, but sometimes the prophylaxis can be missed. And initially during treatment it may not be necessary, but if you have somebody come into the hospital, they're stabilized on a prednisone dose or able to be discharged on a prolonged taper, that might be when to make sure that these medications go along with the patient. Or they hopefully can be added on in clinic if it's missed during the hospital stay. Okay. So then we have at least a few minutes here at the end to talk a little bit about our last patient case. So this will be a patient who has been on atezolizumab for metastatic non-small cell lung cancer. She had previously been on a platinum-containing regimen and then had disease progression, so this is being used in the second line. She's had 5 cycles. This is given every 3 weeks, so she's about 15 weeks into treatment. And she's having this elevation of her AST and ALT when she comes in for a lab check. Here are her other medications and past medical history. So she is hypertensive and is on losartan, has type 2 diabetes on metformin. She developed hypothyroidism on atezolizumab and is currently stable on a dose of 75 micrograms daily of levothyroxine. And so any other cause of hepatotoxicity has been ruled out, so it's always important to kind of go through that workup. If a patient, she's 67, so she probably falls into that bracket of patients that should be checked for hepatitis C. You never know, but ruling out that, liver metastases, etc. So it's determined based on the time of onset and everything else being negative that she is actually likely has developed immune-mediated hepatitis from her atezolizumab. So for the grading, since I don't think you have access to the slides, I will pull up the hepatitis grading slide so you can see. So if she's grade 3 to 4, it would be at least 5 times the upper limit of normal. But if it's 2.5 times the upper limit of normal but less than 5, then she's considered grade 2. So the break point will be the 5 times the upper limit of normal. Plus her labs there. So based on that, if her AST is 110 and in this range it's a 35 is the upper limit of normal, she's about 3 times the upper limit of normal. And then her ALT would be 49 is 3.5 times the upper limit of normal. So she kind of falls right into the range of a grade 2 hepatitis. So based on that, what treatment would you recommend? And then all of her supportive care and counseling. And then whether or not, because the next question will always be, so we're going to get this all fixed and figure out what to do, but what happens with the atezolizumab? So just keeping in mind that she has grade 2 hepatitis, likely from her treatment. So we'll take several minutes. It is 10:54, so we'll just take a few minutes to go through these, and then we'll talk about them. Alrighty, so we'll go over Ms. AR. So what treatment did you recommend for her grade 2 hepatitis? And this can be a very broad answer. Doesn't have to be too specific, but also go back to the slide. So she falls into this grade 2, so we would hold the immune checkpoint inhibitor therapy, but then we would also do the systemic steroids. The dose sometimes can fluctuate depending on what reference you look at, just because this is kind of a newer area of determining which dose, but it would still be systemic steroids, probably closer to the 1 milligram per kilo per day, but regardless, it'd be high dose steroids tapered over at least a month. So then what sorts of supportive care based on this patient's particular past medical history and how long they may be on steroids do you want to make sure to educate the provider and the patient about?
Can I aggravate hypertension and diabetes?
Sorry, what was that?
So is this anybody's question or did you call me?
Oh yeah, just anybody's question.
Can like aggravate the hypertension and the diabetes because of the steroids?
Yes, so definitely she already has a past medical history of hypertension, so that may get worse with the steroids, and she's a type 2 diabetic, so her blood sugars may get worse with steroids. And similar to the patient case we talked about with melanoma, she's probably not checking her blood sugar at home because she's only on metformin, so it's just something to keep in mind that the patient may need to get a glucometer at some point, and that it's not to let her not be alarmed when inevitably it goes up with that much steroids. And then looking back at our supportive care, so it would be if she ends up having to taper over at least a month, then she may need to consider PJP prophylaxis. She, depending on her past medical history, if she's been exposed to zoster at any point is at risk for reactivation, that can be considered. She may not necessarily be a patient that needs a PPI or H2 antagonist because she doesn't really have those other risk factors for developing gastritis, but it's something to consider and maybe look into a little bit more if she does have any risk factors, and that she may need management of osteoporosis with calcium and vitamin D supplementation, which for a patient who's 67, it may not hurt in general. Maybe she should be on one regardless of being on the steroids, but if she's not, maybe this is an opportunity to assess whether or not she has appropriate calcium and vitamin D supplementation for her osteoporosis. As far as what should happen with her atezolizumab, so in a setting of grade 2, for most of our toxicities, you can probably resume the immune checkpoint inhibitor. Grade 3 and 4 is when you may need to consider permanently discontinuing, with the exception of things like hypothyroidism or other endocrinopathies where you may still be able to resume after, but for most of our other toxicities, once it's grade 3 or 4, that's when we have to consider a permanent discontinuation of the immune checkpoint inhibitor. But for this patient, since it's grade 2, she'll likely be able to resume once she has been tapered off the steroids and the hepatitis has resolved. What questions do you have? I think the slides should be up very shortly for you. And I'll have the colorectal slides posted probably the day, at least the day before, if not several days before Friday. Alrighty, and I know I tend to talk a lot, but you feel free to email any questions, but your, the exam questions, the information will be on the slides, so don't worry if you feel like you didn't have notes to take with the slides. You'll be able to get everything from the slides once they're posted. No worries.
The pre-class and the class slides, or just the one thing class?
For both, I don't think there's a whole lot extra from the report. The question was whether or not that applies to the pre-class, I believe so. I don't anticipate asking anything that I said as an offhanded comment. So, yes, so just focusing on what's on the slide, supportive care, and I think colorectal won't be as long, hopefully, since we've talked a lot about the immune checkpoint inhibitors already, so there might be some time we can re-go over anything from lung, because it's a lot of info. So, thank you.
Thank you.